It's
All right. Thank you for this very nice introduction. It's a pleasure for me to be with you today and share with you some information regarding the dietary management of patients with liver disease. I'm sure you're all very much aware that the liver is a very important organ in the metabolism of nutrients. Nearly all the nutrients that are absorbed in the GI tract have to be filtered by the liver, where they can be metabolized. For example, for protein, this is in the liver that ammonia, which is a product of amino acid degradation, is detoxified to make urea. Also, that's the liver that is responsible to maintain the level of amino acid in the plasma. If it's too high, the liver will degrade amino acid. If it's too low, the liver will produce amino acids that are necessary to maintain that level. The liver is also involved in fat metabolism. For example, the liver will remove all the fatty acids that are present in the bloodstream because fatty acids is toxic. It's like a detergent, of course, if there is too much of it. And those fatty acids, then the liver store them either as triglycerides, phospholipid. It can use fatty acid to make cholesterol. Finally, the liver will package of those lipids in what we call lipoprotein, which will be a kind of a carrier to bring those fatty acids to all the cells that need it. The liver is also very important in carbohydrate metabolism. After the meal, when there is too much glucose in the bloodstream, the liver will remove it and store it as glycogen. Then the further away from the meal, when glucose goes down, then the liver will release that glucose to maintain glucose in the plasma. Also, the liver is the only organ that can use amino acid to make glucose. Finally, the liver is involved in the storage of many nutrients like vitamin A, vitamin D, but also vitamin B12, for example. It is involved in the storage of trace elements like iron, copper, zinc, manganese. And finally, also the important role of the liver is that it will allow some biotransformation. For example, there are some molecules that are not active when they enter the liver, and that the liver will transform so that they become active compounds that can be of very high interest, and that can be some special ingredients, so some special antioxidant, for example. On the other hand, you have some compounds that are toxic, and the liver will transform them so that they can be removed from the body through the bile or through the kidney. Oops, sorry, I went too fast. Now we have to have some questions.
Yeah. So it's time to poll questions. Can we have a poll questions on screen? Team, can we have a poll questions on screen? So first poll question is related to the dietary management in case of hepatic disorders. And the poll question is, what is the particular role of or goal of a dietary management in case of liver diseases or disorders? And options will appear in front of you. You need to select the appropriate, the or most correct answer for this question. You will get a 1 minute's time. So please mark your answer. Thank you for your responses. And now I request Vincent sir to please clarify. Yeah. Thank you. Over to you, Vincent sir.
Okay, what are our goals in the dietary therapy of patients with liver disease? The first and most important one is to correct and prevent malnutrition. In a few slides, I will explain to you why a patient with liver disease do suffer from malnutrition. And I speak about patients with already advanced liver disease at very early stage. If you have a slight increase in liver enzyme, it doesn't mean that you will suffer from malnutrition. The second one is to minimize hepatic parenchymal damage. As you will see, some nutrients can damage the parenchyma in a sick liver. Finally, we will promote regeneration. The liver is a very special organ that is very good at regenerating, but it has to have the nutrients that are necessary for that generation. And finally, we want to prevent or minimize the most common complication of liver dysfunction, that is encephalopathy and liver encephalopathy, I'm sorry, and ascites. As you know, there are many liver diseases, and of course, one diet will not fit all those diseases. Some of them are much more common. So the diet that are designed for patients with liver disease are specially formulated for patients with portosystemic shunt, for hepatic fibrosis, for Canin chronic hepatitis, copper storage disease. But there are some hepatic diseases like hepatic lipidosis that will not respond very well to such a diet, and I will go into detail over the time of that presentation. So as an example, for example, hepatic lipidosis, which is a common disease, it's the most common liver disease in cats, is not doing well if you feed those animals a diet that is moderate in protein, is moderate in fat and low in copper, which are the composition of the common liver diet. What you need to give to those animals is rather a recovery diet. That is a diet that is high in protein, a diet that is high in fat, and a diet that is low in carbohydrates. In the case of hepatic shunt, on the other hand, you want to bring a low to moderate level of protein to avoid producing too much toxin. You have to have a diet that will also promote the good fermentation in the eye gut, that will promote acidification of the eye gut. In chronic hepatitis, once again, depending on how advanced you are in the disease, you may want a diet that is moderate or low in carbohydrate, protein, and you also want a diet that is low in copper. So you see, the requirement, depending on the disease, is not exactly the same. And so when we did design hepatic diet, we tried to take into account most of the diseases, but some diseases cannot be included in those diets. Anorexia is quite a common problem in patients with liver disease. So of course, you want that diet to be palatable, but even if the diet is palatable, in some patients, that's not enough, and you will have to consider tube feeding. And since I heard that my colleague Catherine spoke to you about that in the last session, you know, it's basically the tube feeding is similar to any other disease. That is, the way you use tube is the same that in any other disease. And of course, finally, the diet must be complete and balanced. That is, it has to contain all the nutrients that are necessary for a dog or a cat. That's protein, but amino acids, essential fatty acid, minerals, trace elements, and vitamins. And that's true also in any disease. You want to give all the nutrients that are necessary, except if some of those nutrients can be an issue in that disease. Okay, no malnutrition. Malnutrition is quite a common complication of patients with liver disease, especially when you advance in the disease. It's easy to understand why, because those animals have a poor assimilation of their nutrient, because those animals are suffering from anorexia, they don't want to eat, because those animals are suffering from nausea and vomiting, and when you're nauseated, when you vomit, you're not really hungry. How can you recognize a patient that is suffering from malnutrition? You have to have at least one of those signs. That is, this animal didn't eat for at least 3 days. This animal has been on an unbalanced diet, for example, a diet that would be made only from meat, because that's the only things that the animal wants to eat. If the animal doesn't show any store of fat, as you can see on this dog is quite extreme, and you don't want to wait that far, but the malnutrition will induce those kind of problems. If the animal suffers from an acute weight loss of around 10% in the last few weeks, if the animal has significant vomiting and diarrhea, and finally, if the animal is showing hypoalbuminemia, you should really monitor this animal closely. You should make sure that this animal is eating on its own, is eating a proper diet, and if not, then you have to consider tube feeding. When we consider correction and prevention of malnutrition, the first things we have to look at is energy. If you don't provide enough energy, the animal will have to use its own reserve, which are first the fat, but then when the fats become limited, then the animal is going to use protein. And protein, there is no storage of protein in the body, so any protein in the body is essential. So the animal is going to use the protein that is less essential, but still essential. And the protein that will be degraded first are the protein that are involved in the immune system, and they are the protein of the GI tract. And so that's not good, because when you're losing protein in the GI tract, when you have atrophy, the gut barrier is not working properly anymore, and so bugs and toxin can cross that barrier more easily. How much energy should you give to those animals? For the dogs, the range is between 70 and 110 kilocalories of metabolizable energy by kilo of metabolic body weight, kilo exponent 0.75. Actually, in hospital situation, we consider 70. Any hospitalized dogs, because they are not moving very much when they are in the hospital, should receive the lowest. And 110 is really for a dog that may have some signs of liver disease, but it's completely normal. It's even relatively active. For coach potato, we tend to recommend more 95. You can see that the equation is slightly different in cats. We're using the exponent 0.711 instead of 0.75. But if you go in hospital, for dogs and cats, they use the same equation, 70 calories per kilo of metabolic body weight for animals that are hospitalized. Okay. You probably know that energy in the food is coming from three main nutrients: the lipid, the carbohydrate, and the protein. In patients with liver disease, because they are often anorectic, don't eat very well, all their metabolism is geared to lipids, which means that when you give them lipids, they can really handle them very well. On the other hand, in patients with liver disease, the fasting, the anorexia, will decrease the ability of those animals to deal with carbohydrate. For example, the pancreas will not secrete as much insulin that it should do. So if you change the diet from one day to the other, the animal will not be able to react to the new diet, to the high level of carbohydrate that is in the diet. And that's the glucose intolerance. Finally, what kind of starch should you choose? Historically, we always said that the rice is very digestible, and you see that on the graph on the right-hand side. You can see on the left, on the y-axis, you see the amount of hydrogen that is released in the bread of an animal that eat that diet. And then on the x-axis, you have the time in hour. You can see that there is not much change for the first 5 hours. This is the transit through the small intestine. And then when it got in the large intestine, you see that the fermentation are much higher with wheat and corn. You have more hydrogen produced than with the rice, which means that there is more starch arriving in the large intestine when you eat wheat and corn than when you eat rice. This is the case if you are eating grain of wheat or grain of corn. If you're using purified starch from those cereals, like in flour, like in starch, then the digestibility in the small intestine is much higher and less left over for the hindguts. I'm sure that Catherine spoke about that in the last presentation, but so if the animal doesn't want to eat and you have to consider tube feeding, what people will mostly use nowadays is the esophagostomy tube. The nasogastric tube is also interesting because it's easy to put and you don't need anesthesia, but it's not much less comfortable for the animal than the esophagostomy tube. The other advantage of the esophagostomy tube is that you can put slurry, whereas in the gastric tube, it has to be very liquid. Okay. The key and important things I will remind you once again is that when you introduce a tube feeding or even a new the diet in a patient that has not been eating very well for a while, you have to be very slow. The GI tract will need to learn again to produce all the enzymes that are necessary to digest that food. And it's not because the animal doesn't eat 100% of its requirement on the first day that's going to be bad. On the contrary, if you feed too much when the GI tract is not ready to absorb all that food, all that diet will get into the hindgut. It will stimulate the fermentation, and the animal is going to get diarrhea. He may also get vomiting, and so you're going to lose another few days. So it's better to go very slowly. For example, 25% of requirement the first day, 50 the second day, 70, and so on. And even you can even make it a little bit longer. If an animal didn't eat for a long time, speak for weeks, then you want to do it even a bit longer on 1.5 weeks. As I showed you, the liver is a very important organ to store energy. So when the liver is not working properly, it's recommended to give several meals during the day, ideally at least 3, 4 more if it's possible. In some cases with a lot of vomiting, the only way to manage that is sometimes to feed continuously, but then you need a tube feed, of course. Enteral nutrition is the key. There are not very many places around the world where we use parenteral nutrition, that is nutrition through the vein. This is very technical and you need to be extremely careful. And the fact is, if the gut is working, you have to feed it. Okay, because as soon as you don't feed the gut anymore, then there will be an atrophy of the gut, and once again, that's going to decrease the barrier of the gut, and you increase the risk of those bacteria crossing the gut, for example. The last point I want to make is to speak about food aversion. I don't know how familiar you are with the term food aversion, but I'm sure most of you have experienced food aversion in your life. One day, you ate too much of a food, during drinking too much of a drink, that made you sick, you had nausea, you had vomiting, and from that day, only the smell of that drink, of that food, make you sick. You don't want to go close from that food anymore. And that's a mechanism of defense that we learn over the many years of our evolution, because we didn't want a human or an animal to eat twice a food that make it sick. So it's good when you eat, when it's associated with a food that makes you sick. On the other hand, if the cause of vomiting, the cause of the nausea is not the food but the disease, then it makes that the animal become aversive to all the diets that you propose. Each time you change the flavor, because that's what matters. They eat it for one day, they feel sick, and they don't want to eat that diet anymore. And so that can be a big problem in patients with renal disease, with liver disease. Okay, the second very important nutrient in a patient with liver disease is protein. Dogs have a dietary requirement of protein of around 12 to 14%. And when I say that, a minimum requirement of 12 to 14%. When I say that, it's when you feed a protein of very high quality, with very high digestibility, and a very good balance of amino acids. So it's not every protein, it has to be a very good high quality protein. For the cat, it's even higher because the cat has to use some protein to make energy. So it's required 20% calorie. So that's the strict minimum that you should give to a patient as a minimum level of protein. Of course, in most patients, we want to give a higher level of protein than that. I wrote there the highest level possible. I mean, we need to be careful. We don't want to give very excessive amount of protein. I remind you, protein is amino acid, and you give too much amino acid, the body won't know what to do with it, so it has to catabolize it. And where do you catabolize amino acid? In the liver. Where do you detoxify ammonia from the catabolism of amino acid? In the liver. So no, you don't want to give a very high level of protein to a patient with liver disease, but you want to give a higher level than the minimum. And there's only one exception to that. It's the patient with hepatic lipidosis, as I will show you. The source of protein does matter. In fact, it has been shown that some proteins are better tolerated than other, and especially the dairy protein and the vegetable protein are better tolerated, especially in patients that suffer from hepatic encephalopathy. What level of protein should you start with? I mean, if you have a patient that is presented to you with hepatic encephalopathy, of course, you're going to go on the low side. Say, for example, 16% protein in a diet, 16% of the calories. You may go to 18. If everything goes well, you may want to increase that level until so that you give a 20 to 25% protein that is well tolerated by the animal. If you have a cat that is presented to you with hepatic lipidosis, you go right away to 35% protein and a recovery diet. If it's a patient with hepatitis that didn't show any signs of disease, again, you can go to a 20, 22, 23% protein with no problem. Among the other nutrients that are commonly low or deficient in patients with liver disease, there is the potassium. Many patients with hepatic disease have a low potassium in their plasma. You need to monitor that, you need to measure it. And of course, if the animal is under fluids, you can complement the potassium through that way. But if the animal is on a tube, it's very easy also to provide that potassium through the tube using a compound like potassium gluconate at the dosage I give you there. That's a dosage per day. You have to be careful though. As you know, a peak of potassium can be dangerous for the animal. It can stop the heart. So you should always give that potassium with the meal. You should not give that potassium outside of the meal at that concentration, at that level. And of course, you know, too little or too much potassium can be harmful for health. So you need to monitor those individuals. You need to make sure that they require potassium because they are too low, or that you should stop adding potassium because they are on the high range or they're already too high. Zinc is a nutrient that is often deficient in patients with liver disease, especially in human medicine, where they monitor it. It's not so easy to monitor zinc in veterinary medicine. That's not something that is offered by the lab. It makes sense because among the trace element, that's the trace element that become depleted the faster in a fasting period. No, that being said, most of the diet do contain a very large amount of zinc, and so if you feed an hepatic diet or another therapeutic diet, there will be plenty of zinc for the requirement of those animals. What you observe sometimes is that patients with liver disease have a longer bleeding time. When you take your blood sample, usually you remove your needle, you leave your fingers a few seconds, and you don't see hematoma, you don't see bleeding, but you will see in some of those patients, you will see hematoma and you will see bleeding. This is probably due to a vitamin K deficiency. Vitamin K in the dogs and cats is coming mostly from the microbiota. If an animal is anorectic, if an animal has received antibiotics, the microbiota can be disrupted, and so not providing enough vitamin K. So the ideal is to give some intramuscular. B vitamins are very important for patient for the metabolism, what I showed you at the beginning of this presentation. So you have to make sure that there's enough vitamin B in the diets. It is the case in most therapeutic diets. The last one is vitamin C. You may know that dogs and cats do not require vitamin C, but vitamin C is produced in the liver from glucose in the dogs and the cats. So if the liver is not working properly, there's a risk that this animal is not producing enough vitamin C anymore. So that's why it is recommended to supplement it. Okay, and again, if you go and you look at the hepatic diet, they do contain vitamin C. All right, so that was for the malnutrition. Now, what about nutrients that could damage the liver? That nutrient is copper. The copper, normally, if you have the right amount, is stored in the liver. It's not free, it's bound to a protein. But if you have an accumulation of copper in the liver, there might not be enough protein to chelate that copper anymore. And if there is not enough, then the copper is going to be as an elemental copper, as we say, that is a free copper. And free copper is an issue because it's a very potent pro-oxidant. Okay, it's called the Fenton reaction. In the presence of oxygen and hydrogen peroxide, the copper is going to produce very potent free radicals that will damage the membranes, that will damage the DNA, that will damage the mitochondria, and so basically will induce inflammation, will kill cells, etc. And so you can induce very severe damage with excess copper in the liver of animals. Why is there excess copper in the liver of animals? One reason might be that there's too much copper in the diet. Another one is that for some reason, because of the disease, the bile cannot be excreted efficiently anymore, and the excess copper normally is eliminated through the bile. And the third one is that some animals, like it used to be the Bedlington Terrier, tend to have a genetic defect, and that genetic defect is associated with an accumulation of copper in the liver. Zinc can be a tool against that accumulation of copper because zinc in the wall of the small intestine will promote the synthesis of another protein that will chelate copper, the metallothionein. Okay. So the copper, when it gets into the enterocyte, will be bound by that metallothionein and will not be released. So it will not be absorbed. And as you know, the turnover of cells in the gut is quite rapid. And so this copper will end up in the lumen again and in the feces. Then the third point that you probably have heard of is that there is a drug that can help at decreasing the concentration of copper in the liver. It is called penicillamine. Basically, it makes possible for the copper to be excreted by the kidney. So this drug works very well, but it has significant side effects, and that's why it's not so pleasant for an animal in its owner to maintain their animal on that diet. So now I'm gonna let the floor to Dr. Vishal for the second quiz.
Yeah, thank you, Dr. Vincent. Can we have our second poll question? So guys, those who are logged in from the cell phone, please scroll down your mobiles on your mobile screen. So you will see the questions just below the question box. So the poll question is, which of the following is or are breeds are predisposed to the hepatic disorders? And your options are Labrador, Doberman, Dalmatian, and the fourth option is all of this. So the question I'm reiterating, the which of the following breed is predisposed for the hepatic disorders? And the options are Labrador, Doberman, Dalmatian, or all of this. Guys, you select any option which you feel more appropriate, and do drop your questions if you have any related to the topic in the chat box. Thank you, guys. Over to you, Vincent sir.
All right. So yes, there are many breeds. I mean, actually, I should go back here. Is that to say that the breeder of Bedlington Terriers have been very good. They have identified the gene that was responsible for the issue in that breed, and they selected the breed so that nowadays the dogs that you can buy will not have that defect anymore. But there are many other breeds that still carry that defect. In some cases, gene, one or several have been identified. In some species, we still don't know exactly what's the gene, but we know it's a familial disease. That is, you can see the same problem in brother, sister, parents, and ancestor. So all those breeds are at risk, and there are many more. If you are interested, you just go on the website at University of California, Davis, the genetic department, and they will list to you all the breeds that have been associated with an accumulation of copper in the liver. So we work a lot with the University of Utrecht to look at the accumulation of copper in the liver of Labradors. And what happened in those dogs is they are not born with with copper in the liver, excessive amount of copper in the liver. It's come progressively during their life. So those animals begin to show clinical signs in middle age, more like they are 5, 6, 7 age. They are not showing those signs at 1 or 2 years of age. And so what happened progressively is that you don't see anything even if you make biopsy. Then progressively, when you do biopsy, you can see signs, but yet there is no increase in liver enzyme and there is no clinical sign. So it's difficult to justify a biopsy. You know, when you're in regular practice, it's okay in research and if owners agree. And then progressively and unfortunately very late in the process of disease, you begin to see obvious signs of acute hepatitis, very high increase in liver enzyme. And, you know, not speaking about 10, 20% above normal for those enzymes, you have several 100 times the elevation of those enzymes, and those animals look very sick. The only thing when you detect a dog, a Labrador, and all those breed at risk with this kind of issue is that to ask to identify the brother, sister, parents of those dogs, because there's a chance that those dogs will also suffer from the same problem. And if you pick it up earlier, there's some treatment that might help those animals and at least to increase their life. Because when you are at the end stage that you see on the right of the slide, it's too late. You know, these animals are not going to do well, and there is nothing you can do about it. So this is one of the studies that we did with the team at Utrecht. Basically, what we have here is two groups of dogs, which had an elevated amount of copper in the liver at the start of the study. As you can see, the normal here, the dotted line, is 400 milligram per kilo of dry weight of liver. And you see those dogs were well above. There was another group also with dogs well above. Then those dogs were put on a low copper diet, an hepatic diet. And you can see the effect was quite dramatic in both groups. The difference between the two groups is that those did not receive a supplement of zinc gluconate, a supplement of zinc, and this did. And so at this stage, what can be said is that the level of zinc that is already present in the diet is enough, and that adding more zinc has no benefit. But this study was actually the first one to really prove that just by using a diet, you could have a very significant effect on the accumulation of copper in those animals. And what I mentioned to you, you need to identify dogs at risk. This is the kind of thing you can do. If you identify that those animals accumulate copper in their liver, you can put them on a hepatic low copper diet. And you can see that in the case of those animals, they went back to normal levels. We did a second study, once again in Labrador, because the focus was with Labrador. There, the individual that we identified were Labradors that had increased liver copper in the liver, either shown by measuring the amount or by looking at the histology. But those dogs had no signs of liver disease, and they had no sign of severe hepatitis at the time. Basically, they were what I just mentioned to you, brother and sister and parents of dog that show the clinical disease. And so we put them on a low copper dry hepatic diet. And as you can see, in the majority of cases, there was a nice decrease in copper in the diet. In some of those animals, we went back in a normal. In other, we were still above normal, but within the safe range. It is considered that below 1,000 milligram per kilo of weight, the liver disease will not progress. And then some of those animals did increase. So the explanation for that, after all the work that has been done there, is that in Labradors, it's not one gene, but several genes, up to 5 genes, that is responsible for the accumulation of copper in those liver. And so those animals that have a different behavior would be a different combination of those genes. But once again, it did show that by simply putting those dogs on a low copper diet, you could dramatically decrease the amount of copper in the liver, either to normal level or within a safe range. In those cases where it was not possible, what could be done and what was done was to give those dogs penicillamine, which would drop very rapidly and very, very dramatically the level of copper. And then by maintaining those dogs on a low copper diet, it would take much longer to be back to excessive level. And when you know that penicillamine has quite a lot of side effects, it's nice to be able to not have to use it all the time and to separate more and more the cure of penicillamine. Okay, as I mentioned to you, the copper is really dangerous for the liver because it's a pro-oxidant, a very potent pro-oxidant when it is in this elemental stage. So that's a good opportunity to speak that in most liver disease, you have inflammation. And when you have inflammation, you also have pro-oxidation. And so the body is well done. There are many ways it can protect itself against pro-oxidant. And so there are some compounds like vitamin C, vitamin E, carotenoids, and glutathione. And then there are some enzymes like superoxide dismutase, catalase, and glutathione peroxidase. You can see that those antioxidants can be in the cytoplasm, they can be in the nucleus, they can be in the mitochondria, they can be in the membrane, and that's the combination of all those antioxidants that is efficacious. You don't want to give only one antioxidant. For example, only give vitamin E, because vitamin E will only be in the membranes, and so it will not protect again, oxidation in the cytoplasm. Just very briefly here, if you read a chapter on nutrition and liver disease, you will see the name of those compounds. Those compounds are not present in diets, but they are sold, at least in America. You know, in Europe, it's a bit more difficult, but in America, they are sold in drugstore in support of renal function and liver function. And so this one is a precursor of glutathione. It is glutathione with glutathione peroxidase is a potent antioxidant, and so it has been shown that in conditions like acetaminophen toxicity, the anti-inflammatory drug, can induce very severe disease in the liver of dogs and cats if given in an excessive dosage, and even in human. The human is more tolerant, but it can be a big problem. And it has been shown that in those patients with acetaminophen toxicity, which is a pro-oxidant, you decrease the sign and you improve the prognosis. You can also see at the bottom that if you add SAMI if you give SAMI to the animal, you have an increase in the concentration of glutathione in the red blood cells and in the plasma. Again, it's not in the diet, but that's something you may consider in patients with liver disease. And this is the same thing with what we call milk thistle. The Latin name is Silybum myelinum. Again, it's an antioxidant. It has been used in human and in animal against toluene toxicity, xylene toxicity, some mushroom that can have a very deleterious effect on the liver. Again, you can buy it as a food supplement, but you cannot buy it in a diet. All right, so the third step in our management of patients with liver disease is to support hepatocellular regeneration. And the most important factor in that is protein. You need to give enough protein so that the liver can be regenerated. Because as you can imagine, there's a lot of protein to synthesize. We already discussed about the level. I already mentioned to you, you want to give a higher level. You don't want to be at the minimum, but also you have to be careful not to give too much. Concerning carnitine, it is something that has been recommended in patients with hepatic lipidosis because carnitine is involved in the oxidation of long-chain fatty acid. It has not been my experience. I mean, I'm not a strong believer of carnitine in the management of patients with hepatic lipidosis, but it's in every textbook, so I have to tell you that it's there. And here I want to illustrate the powers of protein in the regeneration of the liver. What we did here was to either fast animal, that's the control group, the yellow bar, versus giving those animals 25% protein, 25% lipid, and 25% carbohydrate, 25% of their energy requirement for 4 weeks. You can see that at the beginning of the study, the level of lipid in the liver of those animals were very similar. But after 4 weeks of fasting, the control and the lipid supplemented group had much more fat. This level of fat is what you can see here. You know, the cells of the liver are completely filled with lipid. On the other hand, you can see that protein and carbohydrate had a positive effect, that the level in cats that did receive protein was nearly the same that at the beginning. And it makes sense that carbohydrate is in between because carbohydrate has a sparing effect on protein. Why in a fasting animal, the protein is used to make glucose. So if you provide some glucose, the body does not have to use that protein to make glucose. You can say also that if you feed a cat a diet that is high in carbohydrate, high in fat, and low high in protein, high in fat, and low in carbohydrate, you can see that within a few weeks, the liver regenerates completely. All that fat left the cells of the liver. Next step now, to prevent and minimize the complication associated with liver dysfunction. And again, we mostly mean here hepatic encephalopathy and ascites. And I would even say we really focus on hepatic encephalopathy because ascites is not a very common presentation. So what is hepatic encephalopathy? It is a metabolic disorder that will affect the central nervous system. What are the signs associated with hepatic encephalopathy? There are nausea, vomiting, tealism, that is salivation, like you can see on this cat here, disorientation, apparent blindness, seizure, and behavioral change. People tend to believe that in hepatic encephalopathy, you see very big signs. It's really obvious, and you're going to get a puppy, and then suddenly that puppy is going to seizure, etc. This is not true. In many animals, the signs are very mild, and often people come for changing behavior. For example, the animal becomes aggressive because the animal is really disoriented. It might take several years before an owner of an animal that has a congenital shunt say, I think my dog has a problem. This issue will be precipitated by events like a high protein meal, and especially if that protein is not very well digested. GI bleeding, because in blood there is a lot of protein, and the protein ends up in the colons. And by constipation, because it keeps all the toxin within the colon. As you will see, the issue is all those toxins that are formed in the colon and absorbed. What are the most common cause of hepatic encephalopathy? They are the hepatic shunt. So they will come in a healthy animal when it's congenital, except for that shunt. But those animals are more or less normal. They might be a bit smaller than normal. The liver is obviously smaller than normal. But and so the only issue there is to close that shunt, which requires surgery and require a very good surgeon. Some surgeons are very good at that. And that's if you're not a very good surgeon and you're not trained to do that, it's not a very easy surgery. Then you can also get acquired shunts. It's basically when you have a fibrosis of the liver, the flux of blood cannot go very easily through the liver anymore. So you have portal hypertension. And so the blood is going to try to find another way and use old vessels that were there during the gestation when the blood did bypass the liver and will bring back to the vena cava, like when you have a congenital shunt. What is the cause of hepatic encephalopathy? This is obviously a toxin, but the exact mechanism is still not completely understood. The things we know definitively is that ammonia has to do something with it, because in every case of a patient with hepatic encephalopathy, the level of ammonia in their blood is higher. But it's not because you have the highest level of ammonia that you will have the highest clinical signs. So ammonia is not the only cause. For a while, people had identified aromatic amino acid, AAA, and that's tyrosine and phenylalanine, as a possible cause. I will describe to you why in the next slide. But basically, when those amino acids get in the brain, they are used as neurotransmitters, and they could have been responsible for those issues, but people are getting away from there nowadays. Then the other issue is all the compounds that can be produced in the gut of an animal with all the fermentation product from protein and for what we call non-protein nitrogen, for example, nucleic acid. And those components could be absorbed, and normally they are filtered in the liver because the liver doesn't do that job anymore. It goes directly in the main bloodstream, can get in the brain and show those signs. And the likelihood is that's a combination of all those things that happen. I forgot about manganese. In the last few years in human medicine, they have observed that patients with hepatic encephalopathy have a higher level of manganese. It has also been seen now in dogs, but the exact mechanism, how does it work, what's the consequence, should we reduce manganese in the diet, is not clear. So this is my little story about branched-chain amino acid. If you take a patient with liver disease, what you will often observe is that the aromatic amino acid, that is phenylalanine and tyrosine, are higher than normal, and the level of branched-chain amino acid, valine, leucine, and isoleucine, are lower than normal. Yet, in the blood-brain barrier, that's the same transport system for all those amino acids. And so the theory was that because this concentration was higher now, there would be more phenylalanine and tyrosine transported in the brain. In the brain, those are transformed as neurotransmitters, and that would be responsible for the signs. This is why, to speak to you about 20, 30 years ago, it was decided to give to patients with liver disease, and when I say human patient with liver disease, a diet that was enriched with branched-chain amino acid and lower in aromatic amino acid. Those were very expensive treatment, and the results were very weak. And so from then, people kind of forgot about that idea. But if you take a textbook in veterinary medicine, they will still speak to you about branched-chain versus aromatic amino acid. Oops. I think it's time for the next.
Yeah, thank you, Dr. Vincent. Can we have next poll question? Yeah. So the next question is about what are the goals of the dietary management in the hepatic encephalopathy? And the options are: first is to regulating the intestinal microflora. Second one is minimizing the ammonia ion and other nitrogenous waste assimilation. Option 3 is both first 1 and 2, and option 4 is none of the above. So I'm repeating the question. What are the goals of the dietary management in the hepatic encephalopathy? And the options are regulating the intestinal microflora, minimizing the ammonium ion and other nitrogenous waste assimilation, or both A and B as third option. And the fourth option is none of the above. So I request you to enter your option correctly and hit submit button to submit your response. So we will come to know what is your response. Yeah, thank you everyone for entering the answers. Over to you, Vincent sir.
Okay. So we do not understand completely the pathophysiology of hepatic encephalopathy, but what we know is that two things in the treatment of hepatic encephalopathy work. The first one is to regulate the intestinal microflora. Basically, we don't want too many nitrogen product getting the iron gut. We don't want too much protein, too much non-protein nitrogen getting into the eye gut, because there it can be fermented by the bacteria and will produce compounds that are toxic when not filtered by the kidney. We know that when we feed those animals a diet that is made mostly of vegetable or milk protein, then we decrease the clinical signs, and I will illustrate that on the next slide. And finally, we know that some nutrients like fermentacible fibers or the fructooligosaccharides that are not digested in the small intestine but are fermented in the large intestine are very beneficial, because they will provide to the bacteria in the iron gut the carbon they need to synthesize their protein, as I will illustrate on the next slide. The second thing that really works in those patients is to minimize the production of ammonia and other nitrogenous compound assimilation. How do we do that? By decreasing the intestinal pH. That's what I told you with the fermentable fiber. When it's fermented, it produces short-chain fatty acids. It will decrease the pH. We want to stimulate the bacterial fixation of ammonia. If you have a carbon chain, if you have ammonia, the bacteria can make amino acid and can make protein. That means that that ammonia will never be absorbed. It will go in the feces. We want to stimulate transit, because the longer we leave the nutrients in the iron gut, the more fermentation we can get. And of course, you don't want to give too much substrate to the bacteria, too much bad substrate, that is a protein that is not digested in the intestine. Also, even if the protein is digested, it's transformed in ammonia and in urea in the liver, and that urea is then secreted again in the hind gut, where it's a source of ammonia again. So you see there's a vicious cycle. So that's why you really don't want to give too much protein to those patients. So this is an illustration of that. It's a study that was done quite a few years ago now. But at the time, they were using the dog as a model of hepatic cell encephalopathy in human, and they divided the group of dog in, and they use a model of shunt. That means that they made themselves a shunt between the portal vein in the vena cava. They divided the dog in two groups. One was fed basically a commercial dry food that was available on the market at that time. The other one was fed what we call a purified diet. That is a diet that is made of soy, hydrolysate, starch, fat, trace element, and minerals. And what you can see here is that the dogs that did receive the commercial diet, they all passed away within 3 months. Whereas those animals that did receive the soy-based purified diet, they were all surviving after 3 months. So it really shows that the diet might make a very big difference in patients with hepatic encephalopathy. Those dogs on the soy-based diet didn't even show any signs of hepatic encephalopathy, when the one on the meat-based diet did show very severe signs of encephalopathy. Okay. So source does matter. And actually, we repeated that study quite a few years after that. So those dogs were dogs that were on a waiting list to get the surgery for shunt. And during that waiting list, owners agreed to either put them on a hepatic diet where the source of protein was a soya hydrolysate, or the same diet, but where the protein was replaced by animal protein. What you can see in blue bar here is that many animals did show moderate to severe signs of encephalopathy at the start of the study. Then when they went on the diet, and by the end of the diet, you can see that the vast majority of those dogs did not show any signs anymore. So much so that some of the owners of those dogs decided not to bring their dog to surgery anymore, because they felt that the dog was doing perfectly normal. Now, we didn't see a big difference between the two sources of protein on the clinical signs. There was in the two groups a very small amount of dogs that still show signs, but we saw signs on ammonia. You see that the dog that received the vegetable protein had lower ammonia in their blood than the control. And as ammonia is one of the most important factors, it supports the fact that vegetable protein is really useful in those patients with hepatic shunt. So this is just to illustrate what I told you. If you give fermentable fiber, what's going to happen in the hindgut is that that fiber is going to be fermented and will produce short-chain fatty acid. Short-chain fatty acid with ammonia will be able to synthesize protein. Where is the ammonia coming from? Either from the degradation of protein in the hindgut, either from urea that is secreted by the colon, in the colon, that bacteria will transform to ammonia and will be used to make protein. So by giving fiber, by giving carbon for a bacteria to synthesize protein, you are able to decrease the level of ammonia that will be absorbed. And basically, that's exactly what happened with the drug that most vets use in the management of patients with hepatic lipidosis, hepatic encephalopathy, when they have clinical signs. They use lactulose. Lactulose is nothing else than a dietary fiber, because it's not digested in the small intestine, and it is fermented in the large intestine. It's for memory. It's a molecule of glucose with a molecule of molecule of galactose with a molecule of fructose. I'm not sure completely of that, but the intestine is not able to digest that bond. So in the hindgut, what's going to happen is that that molecule is going to be transformed to lactic acid, acetic acid, short-chain fatty acid. That's going to decrease the pH. When you decrease the pH, you have more H plus available. H plus is going to bind to ammonia, and when you are under ammonium, this cannot be absorbed. Okay, and also with those carbon skeleton, ammonia can produce amino acid that will be used by bacteria. Okay. The other advantage of lactulose is that it's going to promote low-grade diarrhea, what we call osmotic diarrhea, by the production of all those lactic acid, acetic acid, and that will reduce the transit time, and so avoid toxic to accumulate and stay in the hindgut. But when I showed you, the fructooligosaccharides and other soluble fiber who do exactly the same job. So it's nice to have them in the diet. Okay, ascites. Ascites is not very common in patients with liver disease. It might happen. It's quite a late stage. It's either due to the fact that there's not enough protein and especially albumin in the blood of those animals. It can also be due to the fact that there is a obstruction to the blood flow within the liver, which means that you have portal hypertension, and because of that portal hypertension, you have release of fluids in the intestinal cavity. So if the issue is a lack of protein, and if it's possible to replete the level of protein of these individuals, the protein will make the difference. Now, in case of ascites, it's not recommended to have a high sodium diet. It's recommended to have a lower sodium diet, especially if it's associated with portal hypertension. And so that's why hepatic diet have a moderate level of sodium in their composition. I think I forgot one question.
No, it's all right. Please go.
It's all right. You want to do it now, or I'm continuing?
No. In the interest of time, we will not take it. Yeah.
Okay. So we are at the conclusion then. As you very well know, the liver is a very important metabolic organ because all the nutrients have to go to the liver to be used by the animal. Malnutrition is a very common problem in patients with liver disease. This is why the main goal of the nutritional therapy is to prevent malnutrition, especially energy, protein, potassium, and some vitamins. We want to prevent liver damage, and that is especially associated with copper. We don't want accumulation of copper in the liver, and diet that are low in copper can help to do that. We want to stimulate liver regeneration, and there it's mostly the role of protein. And we want to prevent a complication, and to prevent complication as hepatic encephalopathy, we have to choose the right protein source, vegetable, dairy. We have to add dietary fiber to the diet to promote a nitrogen trap in the hindgut and promote acidification in the hindgut. And for the sake of time, I think I'm going to stop here because this is mostly what I wanted to tell you. Thank you very much for your attention, and I'm open to question now.